This is the Postgraduate Pediatric Orthopedic video series. I'm Satalish Wright. I'm a pediatric orthopedic surgeon. In this video, we'll continue our discussion about guided degrowth with epiphysiodesis or hemiepiphysiodesis. We've seen in a previous video that epiphysiodesis can be temporary or permanent, and we discussed one of the temporary options, which is A-to-plate epiphysiodesis. We talk about indication, surgical technique, and complications. In this video, we'll focus on the screw-epiphysiodesis, which has become a trendy and more surgeons utilizing screw-epiphysiodesis in a preference over the A-to-plate. Several advantages have been claimed, and these can be summarized into the fact that the screw-epiphysiodesis can be performed through a smaller incision. It is a quicker surgery, less prominent metal wear, quicker recovery for the patient, easier to remove the metal wear in the future, cheaper than A-to-plate, and equally effective if not superior to the A-to-plate. Several publications have been published with a systematic reviews, meta-analysis, or case series to support these advantages. However, these publications have been published in the last 5 years and usually focus on the integrate technique, in which the head remains on the metaphysis and the thread in the epiphysis with a cross pattern or a parallel pattern. Recently, a publication by Ahmed Abdelaziz from Egypt, he looked at the retrograde epiphysiodesis, in which the head sits on the epiphysis and the thread going to the metaphysis. This is obviously easier technique to do than the retrograde one. Our case study is the same case we used in the A-to-plate epiphysiodesis. 13-year-old girl, renal failure and on dialysis. She initially developed left genital valgum, but we treated this with A-to-plate and this is fully correct. However, the other side developed genital valgum in the same way. So we decided to take her to theater for screw epiphysiodesis rather than A-to-plate this time. For this are the same I mentioned earlier. It is smaller surgery, smaller incision, quicker surgery, and there's no metal wear prominence, and the fact that the screw can be removed easily. So the patient in theater fully prepped and draped using chlorhexidine, tourniquet applied, and we marked our growth plate here. The second thing really, we marked the trajectory of the screw on the AP direction, and we try to see what the best way to get it in the perfect position, and we felt this will be the perfect position for the screw as you see it from the AP. Then we try to see it from the lateral to have the trajectory as well, and this is probably the perfect trajectory for the screw. Again, we mark it on the skin. And so once we marked it on the skin, we introduce the wire percutaneously down to the bone. Then we check on the AP and the lateral, and we just engage the wire into the skin, into the bone. Then we check the X-ray on the AP and the lateral. Once we are happy, we advance a bit more to what we think is the right depth. That's once we're on the right depth, we open the skin, only the skin, and then we apply dissection down to the bone. We measure the screw length and we drill the outer cortex only. Then we put our screw. As simple as that. Again, it is a finger tight. At the end, we're going to discuss what the best screw size or the type of the screws. These are one of the questions that you might get asked in the exam, but we'll cover it at the end of this video. Then we wash the wound and we close it with an absorbable suture. Then we put local anesthesia, then pressure band. And now we move to the other technique, which is getting very popular now, which is the retrograde technique. Case study: 10-year-old boy, the bone age is 12.8, right fibula hemimelia, leg length difference of 1.8 cm exclusively from the tibia, and expected leg length differences at maturity is 2.2, and the patient is symptomatic. So we decided to do left proximal tibia epiphysiodesis. We mark our trajectory both on the AP and the lateral, and we check them on the X-ray, the right direction. The AP is more important because we need to get our screw in the junction between the lateral 1/3 and the medial 2/3 of the hemiphysis, as you can see in this picture. And once we are happy, we anchor our K-wire into the epiphysis on when we think is where the screw head should rest. Then we engage it just before the physis, and we check it again on the AP and the lateral. And if we are happy with both the AP and lateral, we can advance it a bit more. So we've seen it both on AP and lateral, and when you are happy, so we advance it more to reach the other cortex. Once we finish putting the K-wire, we can introduce our screw or simply put the K-wire on the opposite side. I don't know which one is better, but I usually put the K-wire on the other side. We usually do it using the marking, but if the marking is slightly off, we can rely on the X-ray. As you can see with this patient in particular, our two wires come very close to each other, and when we put the screw, slightly bended our wire. If this happens, it's not the end of the world. Simply just put another wire in a good position slightly away from your screws, then put the screw. Anyway, so we put our K-wire, we changed it, and we get good position wires. This on the AP, on the lateral. Then after that, the normal procedure. Usually we small stab to the skin, and then blunt dissection down to the bone, then measure our screws, then drill the outer cortex. Don't drill the physis, just outer cortex, little drill. Then we'll put the right size screw. Two things you might get asked: would you use washer or no washer? Initially we didn't use washer, but we kind of regretted it when the bone is soft, because the screw gets sunk into the bone and sometimes migrate. So we started to put washers with all our screw epiphysiodesis. That's number one. Number two, would you engage the other cortex? Again, we don't know for the answer for that. We thought by engaging the other cortex make the epiphysiodesis stronger and work quicker, but we regretted that because it caused screw bending and difficulty in removing it in the future. So currently we don't engage the other cortex, simply we leave the thread in the metaphysis. Some of the questions you might get asked in the exam, and indeed this is what we asked ourselves when we moved from 80 plate epiphysiodesis to screw epiphysiodesis. How safe is screw epiphysiodesis to the growth plate? The answer from what evidence available, they are pretty safe. There's no reported incidence of permanent growth damage. However, we're still very cautious and we prefer to use it above the age of 10. If they're under the age of 10 or younger children, we might prefer to use the 80 plate epiphysiodesis. I reiterate, the evidence didn't show there's permanent growth plate damage with screw. However, this has been taking the principle of first do no harm, and because the evidence is not yet strong, there's no definite damage to the growth plate, we prefer to do it in this way. And which screws are the best and what size? We prefer stainless steel size 6.5. We use a smaller size titanium. Unfortunately, it's bended and it was difficult to remove them. Do we have to engage the contralateral cortex? And we mentioned this earlier. We used to, but we stopped this. We leave the thread in the metaphysis. So our current standard, we prefer to use screw epiphysiodesis in those above 10. And we use stainless steel screws 6.5 and higher, and we don't engage the other cortex, and we use washer. And now we completed video 2, and we still have video 3 and video 4 to come very soon. We hope this video will help you in passing your exam and also in your practice. On behalf of the Postgraduate Pediatric Orthopedic team, we would like to wish you all the best for your exam.